much, Nick. We're going to move on. It's my pleasure now to introduce my colleague and your course co-director, Dr. Bobbi Pritt. Dr. Pritt received her MD and did her residency in anatomic and clinical pathology at the University of Vermont prior to joining us for a fellowship in clinical microbiology at Mayo Clinic in Rochester. She then left us for a short period of time to do additional training at the London School of Hygiene and Tropical Medicine, where she got a master's degree in medical parasitology. She's currently the director of the Clinical Parasitology Laboratory at Mayo Clinic, the co-director of the Vector-Borne Disease Service, and the director of the Infectious Diseases Pathology Work Group. She has recently been appointed as a fellow of the American Academy of Microbiology, which is quite an honor in our field of clinical microbiology. And for her fun fact, she has an amazing blog. If you're not aware of it, her blog is called Creepy, Dreadful, Wonderful Parasites. And the amazing thing to me is that this blog has 30,000 page hits a month. That's 30,000, I said that correctly. She has followers all over the world, and I encourage you to take a look at this. You can learn a lot and certainly see a lot of interesting cases that she shares on a regular basis. Today she's going to talk about interesting cases with a focus on 16S ribosomal RNA gene sequencing. So, Bobbi?
Thank you, Robin, for that really kind introduction. So I will not be talking about parasites today, but I will be talking about an important topic, which is 16S ribosomal DNA testing. And so just a quick question for the audience. How many of you have considered asking your lab to perform this test, or have had colleagues saying, oh, we should really do 16S testing? Just raise your hands. Okay, so this is really starting to become more and more well-known. I presented a different talk at ID Week just last year, and there were less hands in the audience, but I think we're just hearing more and more about this these days. So I have a couple of case studies. The first one is the longest, the second one is pretty short. So we'll start with those. First, I'll say that I have no conflicts of interest. So our first case, this is a 67-year-old man, known long-standing history of mitral valve regurgitation, recent decrease in effort tolerance with shortness of breath, but no systemic symptoms such as fever, night sweats, weight loss. He did have recent dental work with extraction of 14 teeth. He was given 1 week of amoxicillin for that. He underwent, at this point, a transthoracic echocardiogram, which was interpreted as being consistent with myxomatous changes of the anterior mitral valve leaflet, and this was thought, from appearance and motion, to be consistent with ruptured cord, leading to